you so much for coming today. We're so excited about this roundtable. We've been looking forward to it. I just wanted to introduce Linda Cady, who's going to be my partner in crime today. And of course, everyone knows Bill Mooney Jr. from the Westchester County Associations. And at this time, what I would like is to introduce the panel and thank them profusely: Dr. John Crow, Dr. John Murphy, John Chandler, Dr. Simeon Schwartz, and Mike Weber.
Well, my responsibilities have changed over the years from simply taking care of patients to somewhat of an administrative responsibility for our group. And our history was that in 1998, we merged 3 groups in town, 2 orthopedic groups and 1 neurosurgery group. The neurosurgery group actually only had 1 person in it. And since then, we've gone from, 9 doctors then to 17, about to become 19. So that's, I think, what I would say my biggest accomplishment was the ability to get diverse groups of doctors together.
I'm a neurologist. I was busy in private practice for a lot of years, missed a couple of meetings, and ended up president of the medical staff at Danbury Hospital, which got me onto the board of directors, which was really a great opportunity for me to see healthcare in a larger perspective. Then had the privilege of serving as chairman of the board for a number of years at the hospital level, and then as the system board chair. My full-time job now is Chief Executive Officer of Western Connecticut Health Network, which is a 2-hospital system. We've recently announced an intention to add a 3rd hospital, Norwalk Hospital, to the system. We have a large employed physician group, home care agency, ambulance services, pharmacies, et cetera. It's a large health system in the Danbury, New Milford, and surrounding towns area. And as chief executive, I'm responsible for it.
I'm John Chandler. I'm president and CEO of White Plains Hospital. I've been in that role for just about 31 years. So I'm trying to think back to what it was like 31 years ago. I've been at the hospital just about 36 years. So I've spent most of my career at White Plains Hospital. White Plains Hospital has grown and thrived over the past 35 years, and I'm very proud of where we are today, the quality of care we deliver.
I am the founder and CEO of WestMed Medical Group. The practice began in 1996 with 15 other friends of mine. We are now today 230 physicians, and we've built these large multi-specialty sites throughout the county that have really improved the efficiency and the quality of care. And we're very proud of the recognition that we have received for both quality and efficiency. But perhaps what I'm most proud of is that WestMed is ready now to enter into a new era of change. We have invested heavily both in our physicians as well as with our employees and systems to be ready for an era where quality and efficiency of care in terms of cost are now rewarded other than just the fee-for-service environment. And it is really exciting to anticipate a whole new delivery system of healthcare, and we hope to be part of the forefront of that process.
I've been the president and CEO of HealthQuest for the last 5 years, and prior to that I was the chief executive officer at Putnam Hospital Center for about 7. Then prior to that, the CFO of Putnam for about 13 years. So I've been around in just outside of Westchester for quite a while now. And we have at HealthQuest, we have 3 hospitals, a nursing home, home care agencies, urgent care centers, physician practices. It's about a $700 million operation. And I think that, I look back at what I'm most proud of, I think, is over the past 5 years is continuing to be successful on all fronts as it pertains to the 3 hospitals, and being able to get the governance changed in the organizations, and also the management structure I changed in all the organizations, so that rather than just saying that we're a system of hospitals, that we really are a system of hospitals.
At this time, I'm going to turn over the mic to Bill Mooney Jr., who's going to kind of set the stage for the healthcare industry in this region.
In our community, there's nothing more important than healthcare from an economic engine viewpoint. Now, let me give you a couple of statistics on healthcare as it relates to the Hudson Valley area. It's $8 billion cash flow right in this region alone, $8 billion. There is nothing close to that. Even our friendly friends from the government can't match those numbers, $8 billion in cash flow. How many people do you think are employed in the hospitals? 30,000 people are employed in the hospitals just around here in this region. Not counting Connecticut, I might add. 300,000 people say hospitals don't pay taxes. Well, the fact of the matter is they do pay taxes. So at the end of the day, before we criticize it, before we whatever, think about what it does for our community. And on top of that, what else do? They save lives.
In the state of Connecticut, that 60% of the population is either diabetic or pre-diabetic. And that in this huge city of Stamford, that there are only 7 endocrinologists. Can anybody kind of tackle that question of where we're moving and what problems that we have ahead of us?
In our system, 40% of the discharge patients, the people that leave the hospital having been admitted, 40% have diabetes. And that number will continue to grow as the epidemic of obesity sweeps across the country. And diabetes often results from obesity. I do think that there is a shortage of endocrinologists. There are only about 200 endocrinologists trained a year, graduating from fellowship training. So they're in scarce supply. And we ourselves have had a difficult time, although 2 are joining us in July, because the demand is enormous. So we're trying to recreate the care team such that the more difficult diabetics see the endocrinologist, but using not only APRNs in the diabetic setting, but also educating the primary care physicians such that they can feel more comfortable treating diabetes. But ultimately, I think we as a nation have to get more serious about managing our weight, because otherwise I think we are in for a very difficult and expensive time with diabetic complications.
What has been the biggest difference that Obamacare has had on either hospitals or practices at the individual level?
I think that this was going to happen independent of Obamacare, but it certainly has accelerated it, which are the formation of accountable care organizations. So part of the bill provides for a Medicare shared savings model whereby which providers are able to enter into a contract with the government where if they meet 33 quality standards, the government will split any additional savings with the practices or hospital practice groups above that 50-50 with the government and the practices. So there is an enormous amount of money at stake for organizations to become more economically efficient in their cost of care. So this idea was out there before Obamacare. It was probably going to pass independent of it. It has already been implemented and probably is not relevant what the Supreme Court is going to decide. And that one small, which I think is like 6 pages of a 2,000-page bill, is fundamentally reorganizing the entire healthcare delivery system. And almost all the private carriers now have jumped onto the same bandwagon. A year ago, less than 1% of WestMed's patients were covered by some form of shared savings model. And by July of this year, we expect 40 to 50% of our practice patients to be covered by that model.
Is that faster than you originally expected?
We expected a decade.
Wow.
I think the reality is, Dr. Schwartz is correct, that the market is changing dramatically. And I think clearly the debate about healthcare reform, a lot of the discussion is driving the market, as it did with Clinton health reform. Actually, if you go back 15 years, when Clinton health reform was being debated, the whole managed care industry really blanketed the country very quickly, and it didn't even matter that the bill finally didn't pass. I think we have the same situation here. And so we are, as hospitals, going to be much more accountable for our cost, for our quality, for our results. We're already reporting that. We're part of a 4-hospital system in Westchester, Stellaris Health. Every managed care contract we sign is now a pay-for-performance contract. So based on our quality, based on patient satisfaction, based on our efficiency, there are incentives built into contracts.
And that'll stick either way.
And I think that's going to stay one way or another. I would argue that if the Supreme Court struck the bill down and if Congress didn't do anything, all of us would continue to drive in the same direction we're moving in right now.
Speaking for private practitioners, it has had a dramatic effect, and it makes it much more difficult for us to react in the same way as a group that has 200-plus doctors or a hospital, because we're under the same pressures to increase our efficiencies, to increase computerization. We never had an IT department before. We have to now in order to do this. And It's difficult for us as a fairly large orthopedic practice to respond, but for the 1 and 2 and 3 and 4 group doctors, it's almost impossible, I think, financially, without them joining a hospital or a larger organization.
I just want to respond to that also. I think Obamacare has just helped push along what was inevitably going to happen anyway. And you know, so from a bigger picture standpoint, I think it's forcing a lot of us to, all of us, to look at being more efficient, focus even more on quality than we ever have before. And frankly, from the standpoint of being efficient, you know, we need to find ways in which we can collaborate better. And I think that's one of the reasons why you're seeing a tremendous increase in mergers and acquisitions of hospitals across the country. And that's just going to continue. It has to. And not only with the hospitals, but with the medical staffs. And that's one of the things we're doing. You know, we have a 3-hospital system, but we need to be much larger than that. We're finding out very quickly that 3 is good, but you know, 6 or 7 or 10 is better.
Dr. Murphy's buying if you're looking for.
Yeah, right, yeah. Right. Yeah, we'll talk.
Dr. Schwartz, you spoke of the shared savings program, that model, and United Healthcare recently announced that it was formed an ACO, or Accountable Care Organization, with WestMed. And so what the financial impact is for patients. I mean, is it and for premium payers? Will they see reduced premiums, and on your end at WestMed, will there be lower physician fees as a result of the program?
The goal of the Accountable Care Organizations is to take waste out of the system. And I know that some people's waste is other people's profit. I appreciate that.
Thank you.
But making the system more efficient begins by transferring more care from the inpatient setting to the outpatient setting. If I polled the audience and I asked how many people here consider a night in the hospital to be a quality experience, most would prefer to be at home. So as we measure how to provide care, we have to begin to look at improved ambulatory pathways and strategies to keep people out of the hospital, out of the emergency room. And when St. Agnes closed, John and I had a lovely conversation about what the impact would be on White Plains' emergency room. And at that point in time, WestMed sort of stepped up to the plate and said, well, you know what, we'll open an urgent care center 7 days a week, and we'll be able to take the healthy patients out of the ER who do not require as intense services, but could now be provided within the community. So WestMed now has 4 urgent care centers in Westchester, and we're seeing in the range of 50 or 60,000 visits a year, which is similar to a large hospital emergency room.
What would be the impact on your physician fees? I mean, is this? I mean, these programs, the ACOs, are they going to lower?
I think that what's going to happen is that the ACOs are going to lower physician fees in the fee-for-service world, but give physicians the opportunity to make the same income because they're going to share in the savings. That's the goal.
How do you deal with some of these costs where people might put them off onto the hospitals because people are showing up at the emergency room? Also, the cost of becoming a physician. It's so great that they want to get out and be a plastic surgeon and not necessarily, you know, a family practitioner. And they might even turn to your own groups and say, hey, can you help me pay for my education? Do you see reform happening and cooperation happening among the legal community, among the schools that educate physicians as well? There's a lot of other areas that need to change, you know, aren't there?
Much of the clinical transformation that is going to be required to survive during healthcare reform will be based upon something called the patient-centered medical home, where we approach, if you recognize that 10% of Medicare beneficiaries are responsible for 2/3 of all of Medicare's costs, we've got to find those patients and assign all the necessary resources to keep them well, keep them out of the hospital, keep them out of the emergency department, and keep them at home. So what we're doing, for instance, is we are looking at debt forgiveness. If they're willing to come join us, we're going to find a way to get their debt paid off, because there aren't enough primary care physicians. There aren't going to be enough primary care physicians.
What plans strategically are being done in the geriatric area? And then if you could maybe also briefly address, if hospitals are looking to expand their wellness programs which may not be as cost-effective immediately, but down the road. Thank you.
Maybe I can just address two of those quickly. We've hired a director of geriatric medicine. We are out and about in the community building geriatric programs. I can't tell you, the demand is extraordinary from every assisted living, every nursing home. We don't have enough resources to provide the support that's there. And I think what's happening is that we're looking not only outside the hospital but inside the hospital, and creating palliative care and geriatric programs as consulting arms within the hospital. We've had a information referral geriatric program for 30 years, but we really haven't had the medical component of it the way we would like, so we're very excited about that, and that's really made a difference. We're also, in a major way, going into wellness and prevention. We're starting, frankly, with our employees, because we felt that to go out to all of you and say wellness and prevention is important, and you say to us, what have you done for your 2,000 employees? And we say, well, we think you ought to do it, but we don't have to. Didn't make a lot of sense. So we've kicked off major initiatives with our employees and gotten great feedback from our employees and are having a good time with it. But I think the whole area of wellness and prevention is going to be more and more important.
It's going from, curing the sick to preventing you from being sick. And that's what the impetus is right now. That's where the financial incentives are going to be going forward. And we all know that. And that's why we're all moving in that direction. But it's the right thing to do besides. Wouldn't it be nice if healthcare was focusing on keeping you well rather than, healing you after you get sick?
Are you guys equipped to, take in wellness requests and say, yeah, we can steer you into this particular program we have? Or is it a work in motion? Or
Wellness is actually a subset of population management, where the provider community now has to enter into a relationship with patients whereby which they provide a comprehensive range of preventative services. And what wellness did was, it was successful because you got a bunch of people who were previously not accessing preventative services to have a financial incentive to do that. But also, those patients are not reached out to by the organizations. And what's changed now is that the analytical systems that we have built in place, we now know the status of the preventative services on every one of our 250,000 patients. And now routinely, we're sending out birthday letters reminding people of what preventative services that they should give themselves for their birthday. And we've had a dramatic increase in our scores for the percent of patients having preventative services. So I think wellness is, the wellness programs by the employers is almost yesterday's strategy. The new strategy today is population management.
We're providing a product, healthcare services, that no one can afford. The government can't afford it. We're spending 17% of our GDP on healthcare, over $2 trillion a year. I think that the quality is spotty and highly variable from one region of the country to the next. But the government can't afford it, states can't afford it. In Connecticut, it's the single largest item in the budget at $4.2 billion. Families can't afford it. 16% of America is in collections at some level because of a healthcare bill or worse. And businesses can't afford it, these double-digit premium increases year over year. So as a nation, I think that we will not succeed on a global stage if we don't fix this problem. And I think that we get into this mess not because doctors didn't care about keeping people well or that hospitals didn't recognize the greater good, but the financial incentives that were structured in a fee-for-service environment, I think, just led us down the path of the more stuff you do, the more money you make, and that were really the incentives built into that model. But I think that game is over, and that you're absolutely right. We now have to focus and celebrate empty beds in a hospital as opposed to full beds in a hospital.
My name is Phyllis Hirschauer. I've been a registered nurse 45 years, but I've been a wellness consultant for 40 of those years. I practice prevention myself. So I'd like to clarify, you had made a statement with regard to 60% of the population being diabetic. I'd like to clarify with regard to prevention. Are you referring to colonoscopy and mammography, or are you specifically referring to education? Education within the community with regard to cause and effect. What can we do to prevent diabetes instead of treat the symptoms?
I mean, I absolutely agree. You can't solve, I mean, I sat on a panel, for instance, on obesity, and it was a fascinating experience for me. I was young in my career and realized, how do you solve as a community obesity? Who do you need at the table? And the table got larger and larger and larger. The more you thought about all of the various facets that had to invest in this. And I think communities have to solve some of those problems, not simply the hospital, not simply the wellness counselor or the doctor. I think communities have to come together and collectively address these very complex problems.
If the premiums are going up at the end of the day, and we're getting less value for our packages, and the hospitals are getting lower reimbursement rates, where's all the money going?
It's been well documented over the past decade or so that the profits of the insurance companies have been substantial. My hope is that the changes that we're going to see in the system that we've all talked about will begin to put the right incentives in the right places.
I haven't seen enough being done in schools in terms of wellness. It's there, but not huge.
One of the things that I'm proud of that we've done is that we view ourselves as an important neighbor in the community. And so reaching out to whether it's government and providing education, screenings for government, doing the same things for school districts, doing lunch and learn for faculty, providing flu shots, whatever we can do to be a good neighbor and to use our resources to help, we do.
The federal government provided under actually the stimulus package before healthcare reform, $44 billion of healthcare IT investment money, and WestMed will be getting about $8 million of that money over the next 3 or 4 years. It's $44,000 a doctor. It's an enormous amount of money, and it more than covers the IT infrastructure that we'll be spending. There's a comparable program for the hospitals also. So the feds really funded completely the IT infrastructure necessary for the change.
The difference is we'll get about $8 million, which won't even come close to paying our costs.
Yeah,
we should be in the doctor business.
If we did meaningful use, we'll end up with about $26 million, but we're spending over 60.
Right, exactly.
So.
Following up on the question regarding treatment of the indigent, the Affordable Care Act failed to address the question of health care for undocumented workers and their families, and who are typically patients in emergency rooms. I wondered if you see is there any solution to that on the horizon?
I think that Westchester is very fortunate. The federal mechanism for funding the primary care for the uninsured is largely through the Federally Qualified Community Health Center. The one that we work most closely with is Open Door, which really has done a fabulous job. So that is the mechanism for essentially free primary care services as well as other indigent care. And I think the business community, it's extremely important that, and I personally support Open Door. I think that it's an incredible resource for the community. It helps decrease the amount of uninsured patients coming to the emergency room, and it helps have a federal funding mechanism for the uninsured, particularly the illegal immigrants.
There's a big issue that was not addressed on immigration, and again, not a political comment. People are here, they're using the school systems, they're using social service, they're using hospitals. It's not like they don't exist and aren't using services. And the government needs to figure that out at some point.
So at this time, why don't we start with Mike Weber in terms of that one dynamic change that you would like to see?
I'd like to see is a way for this country to figure out how to hold its citizens accountable for their health care.
Mine is not quite as global, but a little more practical. This community needs strong practices. It also needs strong hospitals. And the largest hospital, which we admit to at WestMed, is White Plains. White Plains' success is critical to the success of the patients we take care of. And if I had one dynamic change, I think that we all need to figure out how the doctor-hospital relationship continues to improve, moving healthcare forward.
I guess what I would really like to see is a systemic change where the incentives for the physicians and for the hospitals and other participants in the system are much more aligned. And again, we may be heading in that direction, but right now there's so much misalignment that every time you try to accomplish something that makes sense, there's always some economic roadblock that's sitting there, and I'd really like to see that eliminated.
I'd like to focus on my work from the perspective of having been a physician for a long time and having loved it, and to preserve the physician-patient relationship and underscore how special it is, how important it is, and that I think that's where healthcare begins, really, is that you as a patient pick a physician in whom you trust and have a good relationship. And that physician is really committed to the notion of service and is properly motivated to be your advocate in all circumstances.
I think it's critical that we form an organization with the hospital or have a relationship to the hospital so we're both stronger, because if we're not, it's going to be a problem for our community.
Without further ado, thank you very much.
Thank you.